This video, titled Buyer Beware, Problems with All-on-4. This is the 15-minute version of this presentation, and it moderately covers the problems with All-on-4 without a great detail of the explanations. If you're interested in this topic, I would recommend you click on the 36-minute version or the full version of the presentation, where we go through a very in-depth presentation of the problems with All-on-4. The upper is a traditional All-on-4 prosthesis, which is large and bulky. The bottom picture are implant bridges, which are very much like teeth. They look, feel, and function just like teeth. So there are a number of major compromises when considering upper All-on-4, also known as maxillary hybrid restorations. First is aggressive bone reduction. Second is the use of angled implants and angled abutments. Third is soft tissue issues are created from the above. The prostheses are rarely cleansable. Speech issues can occur. Tooth breakage and denture breakage are also very common. The traditional All-on-4 protocol requires 1/2 inch of bone removal per arch, or 1 inch bone removal for the whole mouth. The technical term for bone removal is alveoplasty. Patients are told they're going to have alveoplasty, but they're never told that it's going to be 1 inch of bone removal. Once bone is removed, it never grows back. This picture was found on Instagram by a dentist who performs frequent All-on-4 treatments, and he was bragging about how quickly he was able to remove this patient's teeth and jawbones. Angled implants and angled abutments create another host of problems. Here's a picture of 2 radiographs demonstrating the All-on-4 protocol using angled implants and angled abutments. Bone does not like this interface, and we frequently see bone loss and tissue loss because of the sharp, abrupt nature of these angled abutments. The next issue are soft tissue problems. And I'll stop here for a minute and just simply say that not all patients are good candidates for same-day teeth. Most of the complications in All-on-4 treatment occur because of the rush to take out teeth, place implants, place abutments, and place teeth the same day. Most patients, from a bone and a soft tissue standpoint, are not candidates for same-day teeth. If you have very poor connective tissue to start with, it never gets better, it always gets worse. So this patient had extractions, implants, abutments, and teeth the same day. Within 3 months, she had lost all the tissue around these implants and abutments. It's a disaster. Here's another patient who saw me for a second consultation, and the same for him. He was misdiagnosed. The implants are improperly placed, and the rush to get teeth in there caused further resorption of bone and gum tissue. Yet another patient who was misdiagnosed. Inadequate bone volume, inadequate connective tissue prior to surgery. What you see here are implants exposed and abutments exposed. And yet another patient who comes in with an infection and pus around this lower front implant, with all of his upper implants visible in the oral cavity as well. All these factors lead to a lack of the ability to clean the prosthesis. With improper contours and improper prosthesis design, food debris and plaque accumulate within days and then slowly start to convert to tartar. Here's a patient that didn't have a good preoperative bone or tissue situation. The surgeon who placed these implants placed them too far forward at too great of an angle, and now this is her temporary prosthesis, which is cleansable because it's wide open, but she can't speak because the air flows over the top of the prosthesis. In order to correct the speech problem, we have to use this large pink zirconium bumper. Here it is in the mouth. And you can imagine between the slide of the temporary and this slide how impossible it is to get underneath this prosthesis to clean it. The problem is that the labs are instructed to create a surface, a tissue surface that follows the patient's tissue. And this is incorrect. This is all concave. It fits over the tissue like a saddle. It is uncleansable. I apologize for the gross nature of this slide, but this is what that same patient looks like 3 months after he received his prosthesis. The bottom side of it is concave and thereby completely uncleansable by brush or floss or water pick. The solution is to make the tissue interface convex, rounded, teardrop shaped, so that brushing and flossing can successfully remove the initial food debris and plaque. Here's a drawing of the implant abutment prosthesis interface. And what I'm showing here is this area. The cylinder is the representation of the circumferential amount of restorative material, whether it be plastic or zirconium, showing that these areas between the prosthesis and the abutment simply cannot be cleaned. There's no technique or device that can access this area between the implant, abutment, and the prosthesis. So bacteria, food, and plaque are trapped there on an ongoing basis. Contrast that with implant bridges, where these teeth are perfectly cleansable like natural teeth. All areas between the teeth and around the implants are accessible to brushing and floss. The upper picture demonstrates implant bridges where the implants are parallel and they mimic the position of the roots of teeth. The bottom X-ray is all-on-4 with angled implants, angled abutments, which are virtually impossible to clean. Here's a picture of a cross-section of an implant bridge, and you'll see here that these areas called the sulcus around the implant are perfectly accessible by floss and brushing. Another issue is speech. Upper all-on-4 creates a significant challenge for the patient's speech. The upper prosthesis must put some pressure on the palatal or the inside tissues to create an air seal. Without that air seal, the patient will lisp during speech. This slide shows the same patient. The top picture is her temporary. The bottom picture is her permanent. In the top picture, she can clean readily, but there is no air seal, so her speech is highly impaired. The bottom picture shows a larger prosthesis that seals the airflow, so her speech is correct, but now she can't clean. That's the choice we have to make when the implants are improperly placed and the abutments are visible. The design of the prosthesis, that is the pressure and the concavity, create an uncleansable situation, but it we have to always pick speech over cleansability because there is not one patient who will accept a lisp after treatment. And finally, tooth breakage and denture breakage are very common in in the All-on-4 technique. Upper front tooth breakage is almost the norm, and denture base breakage is also very common. Another category that I'll place by itself is ethics. There are many patients who go in for All-on-4 consultation who have perfectly good teeth. This was a patient of mine who came to see me with about 23 very good teeth. She had some compromises. She went into an All-on-4 center, and this is how she came out. She lost 23 perfectly good teeth this day to make way for an inferior treatment with implants. This is her final outcome. So she went from small, healthy teeth to these very large dentures on implants. Again, because the implant position was wrong, the angle was wrong, she had to have angled abutments, and now she can see the two upper left implants and the lower left implant, to which she highly objects. Here's a comparison chart between All-on-4 treatment and implant bridges. You can pause here to review these more closely. So what are the alternatives to All-on-4? Implant bridges are the very best alternative to All-on-4. This patient came in with failing dentition, fairly good tissue, and fairly good bone. This is her result the day we give her implant bridges. They look, feel, and function like natural teeth, and they're cleansed as easily as natural teeth. This is her final X-ray. The other option is an overdenture or a snap-on denture. This patient came in with multiple failing teeth. We took those teeth out. We placed 8 implants. These are called abutments. They're the part that screws into the implant and provides the snap fit with the denture. These are attachments. It's a male-female connection, and these blue rings snap onto those gold abutments. It's a very rigid, very strong connection. It gives the patient the ability to chew almost normal with normal bite force, but also he can remove this prosthesis to clean it outside of his mouth with a toothbrush, and then clean the abutments in his mouth with a toothbrush. The aesthetic result for implant overdentures is beautiful. We can make any smile we want. And the other big advantage about doing less treatment in the beginning is that we can upgrade in the future. So if the case is planned properly and the implants are placed properly, an implant overdenture can be upgraded to fixed bridges in the future. This gives the patient many advantages. First, we don't have to remove as much bone as All-on-4. Second, it gives the patient a financial breather. These treatments tend to be half of All-on-4, and you can then take a few years to save money and come back to do the fixed bridges. So what if you already have All-on-4? If you have problems as described earlier in the presentation, my recommendation would be that you consult with a board-certified prosthodontist to learn if you have any solutions for correcting those problems. I'll finish by showing you 3 cases of before and after pictures. Here's a patient who lost his teeth because of cavities, And you can see on the bottom slide he has implant bridges and a lower hybrid. The next patient neglected his teeth for many decades and finally came in. He had waited long enough that he did lose enough bone that he needed some pink zirconium. But before and after here is another remarkable difference. And finally, a lady who had waited 30 years to have her teeth restored. She was wearing an upper denture and had these remaining lower 7 teeth, and her outcome, again, night and day from where she started. So I'd like to thank you for your attention and remind you that if you'd like further discussion about any of these points, we have the 36-minute presentation. The full presentation is available on this website. This 14-minute presentation has just scratched the surface with all of these discussion points. Thank you.